Thank you very much, ladies and gentlemen. Good afternoon and enjoy your lunch. I would like to thank the organizers for inviting me to give this talk, and you may see that on the program there are actually two of them, but that's just a mistake, so it's impossible to make a talk in 2 minutes. So that will be just one talk about unraveling causes of hypertrophic cardiomyopathy. And I think that the most important is how we handle distinct cases. So I will share with you two cases we received in our department, and you will see how difficult sometimes it is to get the right diagnosis. So we will talk today about hypertrophic cardiomyopathy. And you may know that there are major differences in definition of hypertrophic cardiomyopathy between the American Society of Cardiology and European Society of Cardiology. But I would like to stick with the definition we have, since I agree with the concept that the patient comes based on the phenotype. He never comes to see you saying, "Hello doctor, I have a beta-heavy myosin chain mutation." He says, "I got problems," and first we do echo or other imaging techniques, and then we see that there is hypertrophic cardiomyopathy. So the definition of European Society of Cardiology is very simple. It's the presence of increased ventricular wall thickness or mass in the absence of other provoking conditions. So when it comes to several cases, like for example amyloidosis, it could be tricky because amyloidosis, we all are putting this in the box of restrictive cardiomyopathy. But at the very early beginning, those patients do not have restrictive physiology. They have some thickening of the myocardium, so they could be, based on this definition, classified as having hypertrophic cardiomyopathy. So this is the long list we have in different causes of hypertrophic cardiomyopathy, and as you can see that we are dividing them into the familial ones and in those which are non-familial. And in our understanding, the genuine hypertrophic cardiomyopathy is the sarcomeric one. So when we are talking about sarcomere, well, we believe that there are proteins which are responsible for hypertrophic cardiomyopathy. Mostly genes are encoding structural proteins of the sarcomere or Z-line or calcium handling proteins, but there are many phencopies, and I will come to that later. So if we look at the published literature, those three groups of genes or pure proteins are responsible for roughly 30 to 62% of different hypertrophic cardiomyopathies. I think that the reasonable estimate is rather the higher, for example, like published by the group from Florence. Roughly 2/3 of those patients do have hypertrophic cardiomyopathy of sarcomeric origin. But what about the remaining 1/3? So it might be that there are genes we don't know yet. And almost each year we see a new publication on genes causing some hypertrophic cardiomyopathy cases. But many of them are so-called phencopies. Many of them are syndromic. They are manifesting as a part of a syndrome which is associated with multi-organ involvement. But why is that important to recognize those patients? It's not because of the multisystemic origin or multisystemic character. It's because some of those cardiomyopathies are actually treatable. We have either causal treatment when replacing enzymes, like for example in lysosomal storage diseases, in infantile Pompe disease, or mostly adult Fabry disease, and we have some treatment also for Friedreich ataxia. So we should think about those patients, because missing the right diagnosis there is a mistake which actually avoid the patient to have a treatment we dispose already of. So it's really important to unravel the cause of unexplained hypertrophic cardiomyopathy. But it's never simple. I will show you two cases before I conclude my talk. The first patient is a 35-year-old male recreational hockey and golf player, complaining of hypertension since 2006, but it was always very well controlled, and he had some palpitations in the past. In 2008, He suffers from right sudden loss of capacity to move his extremities, and he also loses his speech. And he is diagnosed on the CT with a cerebral infarction with some secondary hemorrhage into the territory of middle cerebral artery. In the same time, his echo is done. It is clearly abnormal, so he's referred to our department. So the first thing we were thinking of was that there is something wrong with his atrial septal defect we have seen. So this was fixed. But then the tricky thing is that there was not only the septal defect and patent foramen ovale, but in the same time the patient's echo looked like that. The thickness in average was around 14 millimeters. And if you may better appreciate it in this long personal axis view. So clearly there is something going wrong with this patient, not only on the level of his atrial septal defect, but also he fills in the definition of hypertrophic cardiomyopathy. His hypertension was always well controlled, so this is not the explanation. The other curious thing about this patient is his ECG. You can see there are no voltage criteria for left ventricular hypertrophy, but there is a short PR interval. So short PR is quite a common finding in different cardiomyopathies, and the common denominator of short PR is a storage of substances within lysosome, within the cytoplasm, and you can see that there is quite a long list. So we can see some lysosomal storage diseases like Fabry disease, like Danon disease. The lysosomal-associated membrane protein is there responsible for the storage of glycogen and glycogen-like substances. The AMP kinase cardiomyopathy was originally believed to be a first non-sarcomeric cardiomyopathy, but it leads also to a storage. Pompe disease, glycogen storage disease, and also mitochondrial diseases, and they also sometimes are associated due to the impairment of the energy handling to a storage of glycogen and glycogen-like substances. So this short PR should let us think about those diseases. So is it there in our patient by chance? Well, we know that, for example, Fabry disease is associated with quite a high risk of premature stroke. Actually, 5% of patients aged between 18 and 55 in the paper published by Professor Arndt Rolfs in Lancet 2005 had Fabry disease. We know that hypertrophy is a characteristic feature for Fabry disease. And also, we know that short PR is perhaps less frequent than we believed, but it is present in Fabry disease. So, is the diagnosis clear? First thing we would do is to send the patient for alpha-galactosidase A activity. And surprisingly enough, it was normal. So the diagnosis is never clear because of association of different symptoms. We should go and perform diagnostic tests very meticulously. We were very keen to know what is going wrong with this patient, so we did endomyocardial biopsy, which was suggestive of storage disease because there was an increased content of glycogen. It is obvious already from hematoxin eosin staining and some increase in content of mitochondria. And you will see it better from this electron microscopy view where there is an obvious accumulation of mitochondria, and many of those mitochondria are abnormal. This is a cytoplasm within the mitochondrial compartment. That's not normal. So a mitochondrial disease was suggested in this particular patient. No lactic acidosis, no other signs of peripheral myopathy, but still high suspicion. The peripheral muscular biopsy actually confirmed our suspicion by showing a decreased activity of respiratory chain complexes, but common DNA mutation, mitochondrial DNA mutation, which were examined, especially those associated with MELAS syndrome, were negative. So we went down and all genome of mitochondrial DNA was sequenced, and we found a mutation in MTTL1, which is the gene encoding mitochondrial tRNA for leucine. And it is known to be associated, this gene particularly, with MELAS syndrome, but this mutation was described in the past already being associated with cardiomyopathy and peripheral myopathy. But those patients mostly were sharing a character of high level of homoplasmy, but our patient, on contrary, had a high level of heteroplasmy. This may progress to MELAS further down during the further development of the disease. So this is a complex disease. This is a multi-organ disease very frequently, and there is something to be done about those patients. We should avoid drugs which are impairing mitochondrial function, like statins, and sometimes antioxidants, sometimes anticonvulsants are effective in those patients. So there are many, many mitochondrial diseases, and the manifestation is multiple, but we shouldn't forget that cardiomyopathy is quite frequently associated with this pathology. The other patient is 55 years old. He was examined for dyspnea in 2003, and the origin of dyspnea was found in his left atrium. There was a large myxoma, and the patient was operated on it. Surprisingly enough, already at that time, he was known to have hypertrophy of left ventricle, but there was nothing done about that. 3 years later, being followed by his cardiologist, this one has read a paper we published on the design of the study where we are screening for Fabry disease among patients with hypertrophic cardiomyopathy. And he was referred to our center. I would like to show you his ECG again. And again, you can see the common character here. I already mentioned that it's not as frequent as we believed, but in this case, it was also present. And this is his echo, undistinguishable from other types of hypertrophic cardiomyopathies. Even having mid-ventricular obstruction, which is not so typical again, but Fabry disease may mimic any disease you may imagine. And we were thinking Fabry disease in this patient first, but we didn't find any other signs of the disease except some spare angiokeratomas. You would miss them certainly if you do not know that the patient actually has Fabry disease. He has Fabry disease, severely reduced alpha-galactosidase A activity, mutation found, and he was started on the treatment, which fortunately managed at least to stabilize this severe cardiomyopathy progression. So, what is the problem with Fabry disease? We all have in our minds that this is a multi-organ disease. Characteristic angiokeratomas, renal impairment characterized by decline of renal function and proteinuria. Many of those patients end up with end-stage renal disease. Those patients are at risk of premature stroke, and again, many of them do have stroke within the posterior circulation. Is it or is it not due to those dolichoectatic arteries within the posterior circulation? A part of them perhaps are due to this, and typical ocular finding. But cardiomyopathy may be the lone manifestation of the disease. Those cases were described more than 20 years ago. And this is one of them described by our colleague Milan Eleder. And you may see that such a huge hypertrophy was due to Fabry disease, and the patient in the same time had no storage within other organ, not even within the endothelial cells, which is believed to be a hallmark of the disease in general. So how frequent are those cardiac forms, cardiac variants? I would say cardiac predominance. Many of those patients do have some other signs of the disease. This is a long list, an incomplete list, believe me, of studies searching for Fabry disease among patients with hypertrophic cardiomyopathies. Some of them are very instructive and very important, and I would like to point on them. The first is the study from the London group showing that if your patient is diagnosed with hypertrophic cardiomyopathy after age of 40, there is much greater chance to have Fabry disease. This is logical. Fabry disease is a progressive disease, and more patients develop left ventricular hypertrophy later in the development of the disease. Then, Mayo Clinic group has published zero finding among patients being referred for septal ablation. Again, this is quite logical. Asymmetric septal hypertrophy is present in Fabry disease, but does not lead so often to left ventricular obstruction. but it may lead, it's not excluded, but in this series, 0 patients were present. Then probably largest up-to-date study showing that if you really select the patients from large cohorts of unselected patients, this study published by Lorenzo Monserrat has shown that the prevalence is quite lower than we expected or than you would expect from really selected populations. Very important study. But 2 other studies, excluding patients with sarcomeric cardiomyopathies, thus focusing on the remaining, let's say, 1/3 of patients, they had found higher numbers. So this is what we should do with our patients in the future. Commercially testing for genes, I have shown you, is becoming available. That will be a current practice in future years. So still there is a remaining part which merits our attention. Non-sarcomeric cardiomyopathies are phenocopy which are in part treatable. And we will hear about the treatment later, so I will not enter into details, but I think that missing the right diagnosis is a medical error we should avoid. Let me thank my collaborators for contributing to this talk and you for your patience and attention. Thank you.